Hi.
Good morning.
I believe everyone from the previous session has left, so you can start whenever.
Okay, thank you. Good morning, everyone. My name is Ashton Johnson, and I'm the Minority Diabetes Prevention Regional Coordinator for the MDPP program at Granville Vance Public Health. Today, I will be speaking with you about the evaluation of the Minority Diabetes Prevention Program, the implementation methods specifically in rural North Carolina, Region 7's experience. So in 2016, the North Carolina General Assembly made funding available to implement the Evidence-Based Diabetes Prevention Program, MDPP, by targeting African Americans, Hispanic Latino, and American Indians. So the funding for our MDPP project comes from the North Carolina Department of Health and Human Services, and is administered by the Office of Minorities. Implementation of the MDPP program in Region 7 began in the year 2017. The contributors to this project are listed here with their affiliations. As mentioned before, I am Ashton Johnson. I am the regional coordinator for the MDPP project at Granville Vance Public Health. Dr. Shannon Ames is a preventative medicine resident data analysis as a part of her public health rotation to receive her master's in public health. Brianna Williams was a graduate student at the time when we conducted this study. She was a student intern from UNCG who assisted with creating the data set for analysis. And Dr. Carmen Samuel Hodge is our translational research implementation specialist at GVPH, and she's an associate professor in the Department of Nutrition, Gilling School of Global Public Health at UNCG. These are all the people who contributed to the study over the course of the past few months. So today's presentation will begin with some background information about MDPP. We'll tell you a little bit about the program and the purpose of this evaluation of the first 3 years of implementation in Region 7. Finally, I will describe the methods we use in our evaluation, share our results, and then conclude with the key takeaways from our implementation. So let's begin with some background information about Region 7 and the NC MDPP program. So with the North Carolina Minority Diabetes Prevention Program, there are 10 designated regions in the entire state. So we are Region 7, and our region, as you can see by the map, consists of 8 counties. There are 8 counties because the print is a little small, are Granville, Halifax, Johnston, Nash, Vance, Wake, and Warren. So Granville Vance Public Health, we are the fiduciary agency and we coordinate MDPP activities in Region 7. Out of the 8 counties in Region 7, 5 that we have are considered rural. So now to tell you a little bit more about MDPP and the program as a whole. So MDPP is a statewide effort to prevent type 2 diabetes through structured lifestyle behavior change programs among minority and underserved populations. The statewide initiative targets increasing awareness of prediabetes by screenings, by doing program referrals, and increasing the participation of minority groups in diabetes prevention programming. This initiative was funded by the NC House Bill 1030, and it provides local support resources to increase minority enrollment in diabetes prevention programs such as CDC's Prevent2. Prevent-T2 is the curriculum which we use for the program for CDC. Because the minority populations are at higher risk of being diagnosed with diabetes, it's what research has shown, it is important to prevent new cases by addressing prediabetes. Research has shown that with this program, that DPP can cut the risk of developing type 2 diabetes. So how do we determine who's eligible for this program? So the program eligibility and description for all of these participants were The participants enrolled in this program met the following criteria. So they were at least 18 years of age and had a BMI of 25 or greater. They could not have been diagnosed with diabetes, meaning you cannot have any diabetes. Or pre-diagnosed with prediabetes by a PCP. 75% of the minority participants in each program series, and there are 75% of minority participants in each program series. That's one of the criteria as well. So DPP is a year-long program series with a total of 22 to 26 sessions divided into 2 phases. In the intensive phase, participants attend weekly group sessions, and typically this is about 3.5 months. In this phase, a total of 16 sessions are delivered to participants using the CDC Prevent T2 curriculum. In the maintenance phase, there are 6 to 10 monthly sessions. So at this point, the lifestyle coaches, and I've referenced lifestyle coaches, but I haven't really said what they are, but the lifestyle coaches are individuals who are trained to give this program and curriculum in all of our counties and all of the regions. So lifestyle coaches can choose to go to lesson 22 and stop or go to lesson 26. If the lifestyle coaches choose to go to 22 sessions, that means that the last 6 months, they will conduct 1 session per month. And so that'll be the last 6 sessions. And if they choose 26 lessons, then the lifestyle coach can choose to do bi-weekly classes during the last 6 months. So the 26 sessions just gives them more time to have a few more. The overall goal of this program is to have participants to lose 5 to 7% of their initial body weight by encouraging participants to increase physical activity minutes to at least 150 minutes per week and to change their eating habits. So how do we gather 3 years of data for this evaluation? Because 3 years of data seems like a lot. Well, over 3 years, 150 participants and 15 completed program series conducted in 4 of the 8 counties in the region. Using weights and attendance data from the completed program series delivered between 2017 to 2019, we calculated the mean session attendance, the weight loss percent, and the proportion using 5% of initial body weight. We also assessed the timing by which the program non-responders could be identified. A non-responder is defined as someone who did not lose at least 5% of their initial weight by the end of the program. Statistical analysis were performed using STATA with this. Now to the results of our evaluation. What do we find? So what do we find about all the participants we used in this analysis? Starting with attendance, what we found. On average, participants attended 18.6 sessions. The median number of sessions attended was 13. Attendance was associated with weight loss success. Among participants attending the 13 plus sessions, 33% lost 5% or more of their initial body weight. And among those attending less than 13 sessions, only 7% lost at least 5%. So we see that attendance is a success in the program. So these are our weight loss outcomes. On average, 5.7 pounds or 2.7 of their initial body weight. This weight loss was associated with an average attendance of about 19 sessions. The proportion of participants losing 5% or greater of their initial body weight was 28%, which is the 42 out of 100. 7 programs had a mean of 47% of participants losing 5% or greater. The range was 36% to 62%. Among participants with greater than 5% weight loss, the mean weight loss was 17.1 pounds or 8.3% of initial weight, and the mean attendance was 21 sessions. The analysis of non-responders included 102 participants who had end weight and a weight at either session 6 or session 8. Among participants who lost less than 2% of their initial body weight by week 6 of the program, which is about 4 pounds for a person starting with a weight of 200 pounds, only 37% lost at least 5% by the end of the program. What this tells us is that the additional attention should be given to participants early in the program who are now losing weight as they should. So what are our conclusions from this? So some key takeaways from this program evaluation are these. Program attendance was good overall. The first 3 years of weight loss outcomes were modest overall, but promising. And compared to the nationwide implementation of DPP from 2012 to 2015, which showed 35% lost 5% or greater of their initial weight, in Region 7, we observed 28% overall and 47% in 7 of 15 programs who lost at least 5% of their initial weight. This is very encouraging, being that this is still a growing program and our region continues to grow and we continue to improve our methods with this program. And this concludes, sorry, I had a few technical difficulties. This concludes my presentation. Again, my name is Ashton Johnson, and I'm at the Granville Vance Public Health Department, and I'm the Minority Diabetes Prevention Coordinator. Are there any questions?
Thank you.
Thank you. Thank you for providing us with the opportunity to share our data.
Of course. I'm really glad you could.
Thank you. Okay, well, if there are no... Are you seeing more challenges with weight loss with COVID? Yes, this is definitely, COVID has definitely been a challenge for our lifestyle coaches, and not just our region, but as we talk to others in the state, it has been a challenge for many of the rural regions, specifically because whenever COVID first came, we all went to virtual classes. Well, if you're in a more rural region, you may have trouble accessing the things you need to carry out the class. And with the class in person, participants are able to build relationships, build bonds, and build support. COVID itself came and turned everybody's world upside down. So there are more challenges with weight loss with COVID. People were home. People, were trying to figure out how to help their students or their grandchildren or kids with school. And we were all just trying to figure out how to cope with, losing our daily norms of life. So there has been a challenge with specifically my program. There were so my group was a group of 9 this past year. So with my group, we had 9 and they were making great progress prior to COVID. Once COVID hit, we did see a little bit of weight gain, but what we did was when the phase restrictions kind of lifted, we started a socially distanced walking group, and I had to have some one-on-one sessions to help individuals focus or figure out how to cope. But once they figured that out, they were back on the right track. Will I be doing the program again and make the changes you suggest? Not sure. Will I be doing the program again? So yes, right now we're going into year 4 of the program, and some of the changes that we're making, we use this research for our region alone to in progress of our participants. And another thing with attendance is when participants miss, it is encouraged to have at least follow up with participants at least 4 times and keep them in the program. Would participants be allowed to retake this program, or is it only available to do once? So they're only eligible to take the program once in regards to incentives, because our participants receive incentives as they go throughout the program to kind of help motivate it. Because how do we tell someone to make lifestyle changes, but we're not giving them the tools to make them? So although they can't technically enroll in the class again and count and receive the incentives, they are more than welcome to come back. I had some of my participants ask, could they come sit in on some of my sessions? And the answer is absolutely yes, if you need a refresher. No problem, Cheryl. Are there any more questions? Thank you. Thank you all for taking the time to listen to it. Thank you. Okay. I think that's all, Elizabeth.
Thank you. As
Thank
Amy
you.
said in the chat, now we have a little bit of a break and our next presentation is at 12 o'clock. So we will see you there to hear Ronnie Bell talk about trends of influenza and pneumonia vaccination. So thank you all for being here and we'll see you at noon. If you're a judge, you are done. So you can email me those scores. Thank you for your help.